Good evening, everyone. Thank you for tuning in for today's lecture, which is part of the Women in Surgery Interest Group lecture series. My name is Joelle Shami. I'm the Med2 representative, and today we have the honor of receiving Dr. Soubra as a guest lecturer. Dr. Maher Soubra is an assistant professor of pediatric surgery at the American University of Beirut. He had completed his medical studies at AUB before becoming a resident in the Division of General Surgery at AUB also. He then completed his fellowship in pediatric surgery at Southampton General Hospital in the UK. Today's lecture will be the second of two consecutive lectures given by Dr. Soubra. We will be talking about esophageal atresia, a rather rare and life-threatening birth defect that can only be dealt with surgically, making it an interesting topic for us to be learning about. During this lecture, we would like to kindly ask you to please mute your microphones, as we will be taking questions all throughout in the chat box. So please feel free to type in any inquiries or questions or concerns that you might have. I will now be leaving the floor to Dr. Soubra if he's ready, and hope you all enjoy.
Good afternoon, everybody. Again, I would like to thank Women Surgeon for allowing me the chance to present to you this lecture. It's about esophageal atresia and tracheoesophageal fistula, which is one of the major congenital thoracic emergencies in the pediatric age group. Now, my intent is really to give you an overall information about this entity from the perspective of, from the surgical perspective and from the way I look at it personally. So the presentation is going to include the definition, then we'll do some embryology and an introduction, then we'll talk about the types of esophageal atresia, and then the diagnosis, the prenatal and the postnatal diagnosis. We will have to mention the associated anomalies because these are important association with this entity. And then we'll discuss the management and the problems in the management, the strategy of the management, and the surgical complications that we worry about as surgeons. And then finally, we'll complete the presentation with the lead sequelae. So let's start with the definition. We're talking about esophageal atresia. So what is the definition of atresia? Usually atresia is, when we talk about the esophagus, is non-development of a part or blockage of a part of the esophagus. And this directly means that we have a separation in the esophagus whereby we have a proximal part and a distal part, and then we will have a gap in the continuity of the esophagus. When we talk about tracheoesophageal fistula, the definition of fistula is a communication between two cavities or a cavity and the skin. But in this case of tracheoesophageal, it's a communication between the trachea and the esophagus, and it should be lined by epithelium. This is a congenital connection between the two organs. So we're talking about a problem in the esophagus and a problem between the esophagus and the trachea. Now, as I mentioned, this is a major pediatric thoracic congenital anomaly. The incidence is 1 in 5,000 to 1 in 10,000 births. It depends on your demographic area. The overall mortality of this entity is less than 5% nowadays. And most of the mortalities are related to associated anomalies, which we will talk about later on. I'm mentioning here that it is part of the Vacterl Association of Anomalies. Vacterl is an acronym for an association of anomalies, and we will discuss this in more details later on in the presentation. Now, for embryology, we have to mention that the embryology and the development of the esophagus and the trachea occur at around the same time, between the 4th and 6 weeks of gestation. And you have to remember that two organs of the gut, including the esophagus and the duodenum, usually form as solid tubes, and then there is cavitation of these solid tubes. So basically, the reason, or at least the etiology of the esophageal atresia is thought to be failure of canalization of the esophagus. So esophageal atresia and duodenal atresia are related to failure of canalization of these two organs. Whereas the rest of the gut, usually as a fetus, forms as a cavitated gut from the very beginning. Now, the tracheoesophageal fistula is because of failure of separation, complete separation of the wall that forms between the trachea and the esophagus. I need to mention this just for you to know, in case you are asked about what are the causes of esophageal atresia. Now, since beginning of medicine and since description of this condition, there have been 5 possible anatomical conditions that occur. And these have been classified by somebody by the name of Gross and depicted in this diagram. So I'm going to start with the most common and then go to the least common. So the most common type is what's called in the Gross classification type C, where you see that the esophagus is blocked, but you see that the distal part of the esophagus is connected to the trachea. So this is called esophageal atresia with a distal tracheoesophageal fistula. This condition occurs in around 85% of cases. It is type C, to remind you, and it is the most common type of esophageal atresia. The second most common is what is called type A, whereby you have pure esophageal atresia and there is no connection with the trachea. Now, if you compare this condition to the first one that I described, to the most common, if you see the most common, the presence of the fistula give length to the distal stump of the esophagus, because as surgeons, what's most important for us is how are we going to join the proximal part with the distal part. So the gap between these two parts is very important for us. Now, in pure esophageal atresia, which is type A, the gap between the proximal and the distal part is a long gap. That's why type A, or pure esophageal atresia, is also known as a long gap esophageal atresia. And this is the second most common type. It occurs in around 8 to 10% of cases. The third most common type is no esophageal atresia, but it's the opposite. It's pure TE fistula. And this is called the H-type fistula. It occurs in around 5% of cases. The remaining types are very rare types, whereby you have esophageal atresia with both proximal and distal fistula, and esophageal atresia with proximal fistula, but these are extremely rare. So what you have to remember is that the most common type is called type C. It's esophageal atresia with distal fistula, and the second most common type is pure esophageal atresia. Now, suppose a fetus is being formed with esophageal atresia. Can we know this about prenatally? Can we diagnose it or suspect it prenatally? So we're talking about prenatal diagnosis for major congenital anomalies. The answer is yes, we can suspect it by the presence of polyhydramnios. Now, what is polyhydramnios? Polyhydramnios is excessive accumulation of amniotic fluid. So you can see on the ultrasound, there's a lot of amniotic fluid around the fetus. And by measurement, we can be able to confirm whether there is polyhydramnios or not. Now, I need to speak a word about polyhydramnios and to speak a word about the circulation of the amniotic fluid. When the fetus in the uterus, in the womb, the fetus is bathing in the amniotic fluid. So the fetus swallows the amniotic fluid through the GI tract. The amniotic fluid goes through the esophagus, stomach, and then most of the amniotic fluid is absorbed through the proximal bowel, mainly in the proximal jejunum. Therefore, any obstruction of the GI tract from the mouth, probably down to the small intestines, will lead to extra accumulation of amniotic fluid, and this is called polyhydramnios. Therefore, now you have to remember that if a mother has a history of polyhydramnios, then the fetus, when the baby is born, or the fetus is born, we have to make sure that there is no mechanical obstruction in the GI tract from the mouth down to the intestines. So this is how we suspect intestinal obstruction and in particular esophageal atresia. Now, There is a particular thing about pure esophageal atresia. In this case, we said that the stomach is not connected to the trachea, and therefore the stomach has nothing to fill it up. The stomach is very small. So in cases where we prenatally diagnose polyhydramnios and you cannot see the stomach, like in this case where you see the stomach is very small, it's called microgastria, then we have to suspect pure esophageal atresia. Postnatally, what will happen? If the baby is born with esophageal atresia, the proximal esophagus is quite small. So saliva is going to accumulate in the proximal esophagus. And therefore, the first sign or the first symptom is excessive salivation. And these babies are described as being the mucousy babies. So these are the first signs of esophageal atresia. If we don't suspect it within the first few hours, and when the baby is stabilized, few hours later, we're going to feed the baby after birth. And what will happen is that these babies will have immediate regurgitation. They will start coughing and choking whenever they are fed. Now, if still it is not noticed and we keep feeding these babies and they have recurrent choking, what will result from this is that they will aspirate, and then they will get the symptoms of an aspiration pneumonia, which are mainly respiratory symptoms. So basically, these babies will end up later on with symptoms including dyspnea, tachypnea, retractions, flaring, and cyanosis, all the things that are related to an aspiration pneumonia. Therefore, it's very important for us to suspect it by the first subtle signs of excessive salivation, or whenever we feed the baby and the baby immediately coughs and chokes and regurgitates the milk. Now, once we suspect it, what is the best way to diagnose it? We have multiple ways. I mean, we have multiple options. We can do a barium swallow, we can do esophagoscopy, we can try to insert an NG tube, bronchoscopy, or do an MRI of the chest. Well, the answer is none of these except for insertion, try to insert an NG tube. So the diagnosis of esophageal atresia is quite simple. We don't need to revert to major tests. All we need to do is try to insert an NG tube. And what will happen is that when we insert the NG tube, in most cases, it will get, we will be able to insert only 1/3 the expected distance that we are expecting to insert. Sometimes we might be fooled because the NG tube might go in and coil within the proximal pouch of the esophagus. So that's why when we insert the NG tube, we have to confirm the location of this tube by taking a chest X-ray. And before we take the chest X-ray, it will be nice to inject 1 or 2 cc's of air, because air will be used as a contrast, and it will show us the esophageal pouch. Now, if on the X-ray the diagnosis is not very clear, then we can inject to the NG tube 1 cc of water-soluble contrast, make the diagnosis, and then reabsorb or re-aspirate this contrast material. I'm going to show you the X-ray of a patient whereby the NG tube is inserted and then is coiling back in the proximal pouch. So this is just enough for the diagnosis. In case we are not sure about the position of the tube, or it is further down or further up or more to the right or more to the left, and we need to confirm it, we can use contrast studies, such in this X-ray, whereby we have filled up the esophagus with contrast studies. This should be water-soluble contrast, and then when we take the X-ray, it should be absorbed again. So this will confirm the diagnosis of esophageal atresia. So once we diagnose the atresia, we have to know what type it is. Is it esophageal atresia with distal fistula, the most common type C, or is it pure esophageal atresia? And in order to differentiate, what we need to do is simply an abdominal X-ray, because if the abdominal X-ray shows any gas in the intestines, this is a 100% direct confirmation or indirect confirmation, of the presence of a distal fistula. Because in the case where there is no fistula, there should be no single drop of gas or air inside the GI tract. So these are 2 X-rays showing esophageal atresia, but in one of them, if we look at the abdomen, we see gas inside the GI tract. If the esophagus is blocked, then this is a confirmation, 100% confirmation that there is a distal fistula connected to the trachea, which is filling the GI tract with gas. In this case here on the right side, there is esophageal atresia, but you can see that the whole abdomen is completely opacified and there's no gas in the GI tract. This is the diagnosis of pure esophageal atresia. So just to recapitulate, the diagnosis is very simple. Try to insert an NG tube, inject 1 or 2 cc's of air inside the NG tube, and take a chest X-ray and an abdominal X-ray. The chest X-ray should diagnose for you the esophageal atresia, and the abdominal X-ray, depending on the presence or non-presence of gas within the GI tract, will determine for you the type of esophageal atresia, whether it is type C, the most common, or is it pure esophageal atresia. Now, once we make the diagnosis, and because organogenesis occurs at the same time in the fetus, we have to check whether this baby has other associated anomalies. And what I'm mentioning here is that there is a group of anomalies that occur together, and the acronym for that is Vacterl. Now, just to emphasize the point, this is not abstract. This is an actual reality. These babies have multiple associated anomalies that we have to look for. Now, Vacterl stands for, the V is for vertebral, the A for anal, C is cardiac, TE is tracheoesophageal that we have been discussing, R is the renal, and L is the limb. So how do we check for these? And is it important or not? Of course, it's important to check for all of these. And the way to check for them is quite simple. For vertebral, we already, during the investigation or the diagnosis, we have already done the X-rays. So the vertebral anomalies can be done by checking on the X-rays. We can check if there is hemivertebra, abnormal vertebra, accessory ribs, additional ribs, etc. So it's very simple. For the anal, it's very simple. What we have to do, and it's important to do a full anal exam, and we can even look at the anus and try to poke the anus with the tip of an NG tube, just to make sure that there is no anal or rectal atresia. The cardiac is the most important of anomalies that we need to check, because cardiac anomalies in these babies will affect the prognosis and will affect our approach to the patient, because we will need to do major surgery for these patients, and therefore the cardiac is very important. And what we need to do for the cardiac is really do a pediatric echocardiography and consult the pediatric cardiac team. For the cardiac, just to mention it, for every single neonate, nowadays, for every single neonate that needs any surgery, we prefer to do a cardiac clearance by doing a pediatric echocardiography before they put the baby under anesthesia. Now with TE, we just mentioned TE. It's a diagnosis that we have already made. So what about the renal? Now, of course, we have to check for the renal anomalies. And the renal anomalies are usually checked by doing 2 tests. For the upper system, which are the kidneys and the upper ureters and the pelvis of the kidneys, we can do an ultrasound. And this ultrasound is enough to give us enough information about whether there is hydronephrosis, whether there is absent kidney, a horseshoe kidney, and it will be enough to check on the meat of the kidney, the cortex of the kidney, whether there is scarring or not scarring. However, the ultrasound is not enough, because it will not give us any idea about the bladder and the function of the bladder. And you have to remember, the most common renal anomaly or urinary anomaly associated with the rest of the anomalies is a functional anomaly, which is vesicoureteral reflux, when the bladder refluxes urine toward the ureters. And this is not seen, cannot be seen by an ultrasound of kidney. And therefore, a renal investigation or urinary investigation is not enough by doing the ultrasound. We have to do what is called the voiding cystourethrogram, which will check for us the lower part of the urinary system and exclude for us the presence of vesicoureteral reflux. So don't forget about vesicoureteral reflux. It's the most common anomaly associated with the rest of the anomalies. Now, so we have to do both these tests, but the question is, should we do them immediately at birth, Well, basically the answer is if the baby is voiding normally and his chemistry is normal, I mean his BU and creatinine are normal, and he has good urine output, and the urine analysis is normal, the answer is no. We don't need to do these investigations immediately at birth, and we can delay them for a few weeks afterwards. But we cannot not do them. We have to do them eventually, but it will be a few weeks on an elective basis. Now, as far as the limbs, it's obvious that if we have a deformity, it will be obvious to us, but just by looking at it and inspecting it, and we can take specific X-rays. So just remember that esophageal atresia and tracheoesophageal fistula is part of the Vacterl, and we need to finalize this before we do anything else to the patient. Now, what about immediate management? The immediate management is really, of course, to put the patient NPO. We don't want them to aspirate further the saliva. And because the patient is NPO, we have to put them on IV hydration. We have to assume that they have already aspirated, and therefore we have to start IV antibiotics against aspiration pneumonia. And we have to suction the proximal esophagus on a continuous basis. And we put like special NG tubes. There are special NG tubes that will allow continuous suctioning because these tubes have alternative ventilation system. Yani they will not get blocked by doing continuous suction. One of these tubes, I'm depicting the picture here, it's called a Plogel tube, and we can insert them and keep for continuous suction. Now, we have to put the patient in anti-Trendelenburg position, yani head-up position, 45 degrees, in order to prevent reflux from the fistula inside the lungs. So these are the immediate orders that we have to go ahead and perform. Now, then we have to look at the strategy. What should we do? Well, this is a surgical entity, and it cannot be resolved except by doing surgery. And there are two types of approaches to the surgery. We have the primary repair, I mean, going immediately for surgery and finalizing everything, doing the full repair immediately. And we have what is called the staged repair. Now, nowadays, most surgeons go for the primary repair. And the staged repair is only left for those babies that are really catabolic, that have major pneumonias, major cardiac anomalies that affect their prognosis, that are considered very major anesthetic risks. And these babies will not have good healing power. There could be also the very low birth weight babies. And in such cases, we will have to do staged repair. Now, just for you to know, the principle of staged repair is that you do something minor to these babies in order to get them in a better condition, in order to move them into a better condition so that they will be able to sustain the major. And we'll come to this later on in the presentation. So let's talk about the primary repair. The esophagus is present in the posterior mediastinum. It is mostly on the right side. So the classical operation is to go through a posterolateral thoracotomy, opening the posterolateral aspect of the chest, going through the pleural cavity, going behind the lungs into the posterior mediastinum. And then in the posterior mediastinum, once we dissect the coverage, we can identify the azygous vein. So it has to be divided. Once we divide the azygous vein, we can look for the fistula, yani the distal part of the esophagus below it. And then once this fistula is identified, it is dissected up to its insertion inside the trachea. And the most important step here is to close the opening in the trachea very carefully and very airtight, because otherwise you will end up with a patient who might develop tension pneumothorax, and this might kill the patient later on. So it's very important to make sure about the closure of at the side of the trachea. Then once we have identified the distal stump and dissected it from the trachea, we dissect the proximal stump, proximal esophagus, and we achieve the anastomosis. Now, there is not much maneuverability of the esophagus. So when we finalize the anastomosis, it is a tight anastomosis. And that's what I mentioned initially. We are worried as surgeons about the gap between the proximal and the distal. So it's completely different from doing a bowel anastomosis where you have enough length of bowel and the bowel can come together very easily. So when we finish the anastomosis, in fact, if you look at it, it looks tense, tight, and it looks like a string of a guitar. Now, lately, over the past few years, there have been gaining grounds for what's called the thoracoscopic repair using endoscopy. And many surgeons now are moving toward this repair, whereby you introduce a scope, you dissect the distal fistula, you just ligate it at the trachea, then you dissect the proximal pouch of the esophagus, and then you do your anastomosis. So, but still, many surgeons go for the classical open repair. Now, I need to mention this strategically because this will dictate to us what is our approach to in the operation. I'm going to read it. Every attempt should be made to join the infant's original esophagus, despite all the technical difficulties that we might encounter, and despite all the risks, because this will be the best option for long-term quality of life. So every single attempt has to be made strategically in order to join the patient's own original esophagus. Any other alternative will not result in the same quality of life. So moving along this strategy, if we find that there is quite a gap between the proximal and the distal stump, there are some maneuvers that have been developed by some surgeons, ingenious maneuvers, in order to try to join the two stumps. On the left side here, there is what is called the Levatides myotomy. I'm just presenting it to make you more interested about the surgical techniques. Well, this principle, this maneuver is based on the principle that the esophagus is made of two layers. We have the muscularis layer and we have the mucosal layer. The esophagus does not have the serosa. So what is not elastic is the muscular layer. So Levatides came and said, what if we do a myotomy and cut only the muscular layer without breaching the mucosa, without cutting in the mucosa? If we do that on a circular fashion, then we can elongate the esophagus and gain around 0.5 centimeter to 1 centimeter in length. So this is one technique to be able to get the two edges together without to achieve an anastomosis. A second technique is what is called the Guff flap. Now, usually in a regular anastomosis, what we do is cut the tip of the esophagus here. But in this technique, instead of cutting at the tip of the esophagus, what we do is cut the anterior surface of the esophagus in a semicircle fashion. So we go backwards by around 1 centimeter and we cut only the anterior part. And then this anterior part is flapped backwards. So in this way, the posterior aspect of the esophagus is brought without tension and anastomosis without tension. And instead of finalizing the anastomosis by doing horizontal sutures, what we do is vertical stitches along the anastomosis. So we stitch the esophagus on its own. So what we end up with is a longer and narrower kind of anastomosis, but at least we will be able to join the two parts of the esophagus. So these are two techniques that can help the surgeon in bringing the two parts of the esophagus together. Now, we mentioned about stitched repair. Just a few words. If the baby is in a bad condition, is a very low birth weight baby, he has a complete collapse of the lung, he has a major cardiac malformation, you cannot do primary repair, because if you do primary repair, you will do the best surgery, but the baby will not survive it. And they will have a high mortality and morbidity. And therefore, what we need to do is, the first stage is maybe do a small operation in the abdomen and place a gastroscopy tube. This gastroscopy tube is placed in order to decompress the stomach. So what we are doing is decompressing the stomach, evacuating the stomach, and at the same time, we will be keeping the proximal tube in the esophagus to decompress the proximal esophagus and to suction it. So what we are doing is preventing any aspiration inside the lungs. At the same time, we will be treating the pneumonia very aggressively with antibiotic therapy, and at the same time also by chest physiotherapy. So the main aim of this procedure is really to treat the underlying pneumonia, and at the same time of the operation, we can insert a central line in order to start total parenteral nutrition. So we will be taking care of the nutrition of these babies. So we'll be treating the pneumonia, building them up nutritionally, and if they have major cardiac problem, this will be the time for the cardiac surgeon to tackle the major cardiac problem until the baby is in a better position, and then later on we delay later on the final repair, the final thoracotomy and the final repair that I discussed earlier. So this is called staged repair in esophageal atresia. Now, so when we do the anastomosis, as surgeons, we are worried about two complications of the anastomosis, and these are peculiar to esophageal atresia and need to be mentioned here. The first complication, which is the early complication, is anastomotic leak. So which means you do the anastomosis and then it starts leaking saliva, usually. This saliva will go inside the pleural cavity. It will develop into pus, into purulent discharge, and you'll get what is called empyema and collapse of the lung and high morbidity and mortality. So we are worried about anastomotic leak, which can occur within few days after the anastomosis. Then we are worried about the second complication, which will be few days later. It will be a later complication, which will be stricture. We are doing an anastomosis, a circular anastomosis, and it is a small anastomosis, and therefore it will, if it scars, it's going to produce stricture and stenosis. So we're going to talk about these two. Now, before talking about how to manage leak, just remember, as surgeons, we look at 5 major factors, important factors for us that we have to take care of in order to prevent leak for anastomosis. The most important one, and the first one, is to have good blood supply on both ends of the anastomosis. The second one is to bring the two ends of the anastomosis without tension. The third will be good surgical technique, and that's why we learn to become surgeons. We have to make sure that there is no distal obstruction, because if you are doing an anastomosis and there is a distal obstruction, obviously it will blow up. And there is no surrounding infection. If you do any suturing or any anastomosis in a contaminated area or dirty area, be sure that your sutures are not going to heal and they're going to disrupt, and you will end up with further leakage. So basically, these are the 5 conditions that we follow, absolute conditions that we follow in order to prevent leakage from any anastomosis. Now, if we look at esophageal atresia, from the very beginning, we are at a disadvantage of 2 conditions. The blood supply of both stumps is not very good, especially the distal esophagus, because the blood supply of the distal esophagus comes retrogradely from the stomach. So we are starting the case with a disadvantage because we will not have good blood supply of the 2 stumps. Second disadvantage is that we will always have tension on the anastomosis. The esophagus is not flexible and they will always have tension. So because of this, irrespective of the technical skills of the surgeon, you can do the best operation and make sure about everything during the operation, but you'll still have a 15% incidence of leak. So this is something that is peculiar to esophageal atresia. And because of this, we have to know how to manage the leak. So the first thing on how to manage the leak is to expect that we might get a leak. And because of this, there's a new technique whereby instead of opening the chest and going transpleural, yani opening the parietal pleura and going between the lung and the esophagus, knowing that the esophagus is in the posterior mediastinum, we can open only the intercostal muscles of the chest and then try to shell the parietal pleura of the chest and go extrapleural. So there is what's called the extrapleural approach. It will add time to the time of the surgery, probably half an hour more at the time of the surgery. but it is a much safer approach, because if you get a leak, this leak will be outside the pleura, it will be extrapleural, it will not end up with empyema and it will prevent the collapse of the lung. The second principle is that we have always to have adequate drainage near the anastomosis. We have to give a good antibiotic therapy in order to treat for the leak, and optimize nutrition. So nutrition is very important. And if we can place a stent within the esophagus so that any leak will heal around this stent. Usually the stent is an NG tube. So basically, these are the maneuvers that we follow in order to deal with the leak, since 15% of patients are going to leak. And we are successful in, if we do that, we will be successful in letting the leak heal on its own within few days or sometimes few weeks. So we'll be able to save these kids, and even if they get the leak. Now, moving to the stricture, usually these do not appear immediately. They will start appearing few weeks after the surgery, usually beyond 2 weeks of the surgery. And of course, if you get narrowing again of the esophagus and the stricture at the esophagus, the symptoms will be recurrent symptoms of regurgitation of the milk, coughing upon feeding, and choking. So once we get these recurrent symptoms, we start suspecting it, and then we'll have to diagnose it. And the way to diagnose it is very simply by doing a contrast study of the esophagus, simple contrast study. And this will immediately show, and then we will decide about the treatment, which will maybe be dilatations. And the preferred type of dilatation nowadays is balloon dilatation under fluoroscopy. I'm going to show it here. So this is an X-ray picture of a patient who had symptoms post-surgery, and you do a swallow, a contrast study, and it shows really dilatation of the proximal pouch. There is narrowing at the anastomosis, which is more than 70% of the size of the diameter of the anastomosis. So this is an indicative of a stricture. And here on the right side in the insert, you can see the type of balloons. It's like Foley balloons that we can insert. So we insert until the balloon reaches the stricture and bypasses it. And then we inflate the balloon. So this is the stricture area here. Then we inflate the balloon and crack the stricture, just break it. And then afterwards, we remove the balloon, and we can keep it for a few minutes and then remove it. And then you end up with a widening of the stricture. So it can be done on multiple occasions, multiple times, multiple sessions. Sometimes you might need one session, sometimes you might need multiple sessions until the baby is able to swallow without symptoms. So now, what about if we have pure esophageal atresia or very long gap and we will not be able to join the two ends? Well, basically here, before we go into the surgical techniques, because there are multiple techniques, and when we have multiple techniques, it means none of them is foolproof. So it depends on the expertise of the surgeon and the preference of the surgeon. However, I need to mention that it has been shown that if we wait on these babies who have long gap until the baby is double the weight, or maybe for a few weeks after life, many of those that you thought initially cannot be brought together will become bridgeable on their own without really changing the surgical technique and doing primary surgery on them. However, if we expect that we will not be able to bring them, then the options that we have are the most common options are the following. The most common that we use is what's the most a la mode now is what's called gastric pull-up operation, where you bring the stomach up in the chest and do the anastomosis. Another option will be to create a gastric tube and join it with the esophagus. And this is a picture showing a gastric tube from the greater curvature, but there are also gastric tubes that you can do from the lesser curvature of the stomach. Or you can place a segment of bowel between the esophagus and the stomach. And here it is showing colonic interposition graft. Of course, you have to bring this part of colon on its blood, with its blood supply toward the chest. This is showing the ascending colon, and another picture on the right side, it's showing the transverse colon. So you have multiple options, but remember the sentence that I read to you before, that every single attempt should be made to bring the patient on esophagus, because this is the best esophagus that the patient can have for better quality of life, long quality of life. Now, once the operation is over and the baby is saved, or they do well, and I told you it's 95% success rate, then what are the late complications? We might have esophageal motility problems, so swallowing problems in these babies for some time, but they will get over it with time. We might get a high incidence of GE reflux, and most of them are treated medically, but some of them will need anti-reflux surgery if the reflux is severe. And some cases will end up with tracheomalacia, whereby the tracheal wall is not rigid, it's very soft, and the trachea collapses upon expiration. So basically they have difficulty in respiration and recurrent infections, and they classically have a typical cough, which looks like a barking type of cough. Now, tracheomalacia usually resolves on its own in most cases, because the trachea will become more rigid as this child goes. So it will resolve within 1 to 2 years of age. But if it is severe, then we can do some kind of operation in order to PEX or fix the trachea toward a solid structure. So these are the things that are related to as long-term sequelae. So I finish here. I hope that just to recapitulate, I want you to remember, or at least what we have to remember, is that esophageal atresia is a major congenital anomaly. The most common type is type C, esophageal atresia with distal fistula. The diagnosis is not complicated. It's very simple when we suspect it. Simple maneuver of inserting a G tube and taking simple X-rays. Then once we diagnose it, remember the Vacterl, we have to check for associated anomalies, and then we have to decide about the strategy of management, whether we do primary surgery in most cases or staged repair if the baby is in a bad condition, and then deal with the problems, the surgical problems, which are related to leakage and strictures. So I'll finish here, and I will wait for your questions if you have any. What if the fetus has proximal fistula and we inject contrast? We put the fetus in danger of chemical pneumonia. Yes, I have to answer this question. So what if the patient has a proximal fistula? As I told you, in case we want to check for proximal fistula, there are two ways. One way is to always do a contrast study. But I told you when we inject a contrast study, it should be a very specific contrast. We cannot inject any contrast. It should be first water-soluble, isoosmotic, so that if it goes from the esophagus inside the trachea, it will not affect the lung, even if you aspirate it inside the lung. And there are types of contrast that we have available for such matter. The other thing is that when you inject it, you inject only 1 cc of contrast, so it's not a big quantity. So yes, you can do contrast study to check always for proximal fistula. It should be water-soluble, isoosmotic, and minimal amount. And then you have to aspirate it at the end of the procedure. Now, for people who don't like to use contrast, in order to check for the proximal fistula, what we can do that is just leave it to the time of the operation, because when we dissect the proximal esophagus from the trachea, from the wall of the trachea, we can make sure that whether a fistula is present or not. So these are the two ways of diagnosing a proximal fistula. What is the most dangerous type among the 5? Well, the most dangerous type, of course, is clinically, initially, is esophageal atresia with distal fistula, because you can get reflux of acid and intestinal contents inside the lungs. And this will add to the severity of your pneumonia, of your aspiration pneumonia. Whereas initially, pure esophageal atresia, because there's no connection with the lung, these babies will do better initially as far as the lung is concerned. They can only aspirate from the proximal esophagus. They don't have a fistula. However, the counterpart is that this condition, pure esophageal, is more technically challenging, and the gap is a long gap. So from the surgical point of view, it is worse from the surgical point of view. Now, what is the most frequently associated Vacterl anomaly in clinical practice? Well, I don't have an answer to this question because they occur quite frequently, many of them. I have many cases in my practice, many cases of cardiac anomalies associated like tetralogy of Fallot or transposition of the great vessels. I have the same number of cases associated with renal anomalies, with like a horseshoe kidney or a single kidney or hydronephrosis of the kidney. Vesicoureteral reflux is also very common. I have conditions really with imperforate anus and absent bones, like absent ulna. So there is no, I'm not aware of any statistics that is most common in the Vacterl association. So you have to look for all of them equally. So because of the long-term morbidity, and what is, okay, because of the long-term morbidity after the surgical correction, how can, and for how long we follow up our patient? Yes. Well, basically, by principle, these patients are followed up for very long periods of time. Sometimes they keep on having reflux and you have to treat the reflux for many years afterwards. So we can carry on the follow-up until adolescence or even beyond adolescent age. However, in most common cases, the sequelae of esophageal atresia, like reflux, tracheomalacia, and all that, you will have determined by the age of usually 2 years or around 2 years whether they have problems from this or not. And in most cases, once you have treated, the tracheomalacia has resolved and you have treated the reflux, usually beyond the age of 2 years, your frequency of follow-up should have decreased markedly. How can and how, okay, are siblings at risk of having a similar? No, this is not a genetically related or familial related condition, or it doesn't have familial incidence. And therefore, the risk of any sibling of the family to have the same entity is similar to the rest of the population. So thank you very much. I will conclude here. And what?
Thank you so much, Doctor.
Okay, thank you everybody, and hope I gave you an overall view of this entity. And thank you again for women's surgeons for this presentation. Goodbye.
Thank you for taking the time of your day to do this. And thanks everybody for tuning in. Hope you guys enjoyed and hope to see you on the next lecture.